Greetings. Welcome to On Becoming a Healer. I'm Stefan Carates. This week, we're going to be speaking about a medical practice that is understood as a helpful way of monitoring addiction and pain care by some, and it is understood as completely humiliating and not evidence-based by others, and it's urine drug testing. So before we get to any further introduction, let me welcome my co-host, Saul Weiner. Hi, Saul.
Hi, Stefan.
And our guest today is Michael Ince of the University of Utah, who's a primary care physician with certifications in internal medicine and addiction medicine, and a lengthy history of work with populations facing serious social challenges, including people with addiction, people who are homeless, and people with pain. Hello, Michael.
Hey, good afternoon. Very happy to be here.
We were drawn to you, Michael, because you had written an article in JAMA Internal Medicine called Reassessing the Role of Routine Urine Drug Screening in Opioid Use Disorder Treatment. And it was a story you told in that article that really made me curious. And I was wondering if you could recapitulate a little bit about the story of your patient with low back pain and a history of addiction.
Yeah. This is a patient that I know quite well and who had spent much of his adult life in the carceral setting, was released and, under community supervision, which jumping through all kinds of hoops to maintain his freedom, truly. And, somebody that was accustomed to being coerced to doing urine drug screens, check-ins with his parole officer, et cetera, et cetera. But despite a lot of adversity, had really just taken advantage of our relationship and just went full forward in terms of improving his health. So we did primary care-based hepatitis C treatment, and he got his diabetes under control. And, he just showed up early to his appointments and wanted to get as much done as possible. It was truly a joy. And he needed to be seen for some acute low back pain at one point. And I was not available, so it was scheduled with another clinician. And because of his diagnosis of opioid use disorder, had a urine drug screen ordered. And, he wasn't prescribed any controlled substances or anything like that. It was a little bit out of the blue. And I think he was a little taken aback. And it was the urine drug screen was positive for a substance that he says that he didn't use. And frankly, I believe him. It was an immunoassay based test, which is pretty prone to false testing. There was no confirmatory testing done. And he saw this even before I did, just because, the results are available through the electronic health record. And it caused him just a ton of distress. And the story is sort of about our encounter, me not knowing that all this happens, and him coming in and, just having been thinking about this and losing sleep about this for several days, into sort of how we approached that urine drug screen in a way that I think ultimately strengthened our relationship, but certainly caused him a lot of distress.
So in this case, I do want to highlight this. The thing that's unique is that oftentimes clinicians, often physicians, are reporting to patients, this is what I found in your urine drug test. But in this case, the patient actually noticed they had been tested, checked the result, and brought it to you with a level of concern about it. There's an illicit drug. Was it? Are you comfortable saying what it was?
Yeah, it was hydrocodone.
Hydrocodone. So a potential prescribed or illicitly derived prescription strength opioid. And, so before we come back to what this meant in the life of the patient, there are two situations I've seen recommendations for getting these urine drug tests, but workup of back pain as an outpatient isn't one of them. Is that a common thing that clinicians would order a urine drug test just for a patient with a painful condition, but no current question of receiving an opioid or whatever from the doctor?
Well, I would say it's certainly not indicated, but there's a lot of sort of we better check. I see an addiction related diagnosis. We should just be getting urine drug screens all the time. And, in addition to it being an $8.5 billion industry, right, it's also an industry in which there's been a tremendous amount of fraud, right, like Medicare fraud and Medicaid fraud for people just doing tons and tons of urine drug screens that are unnecessary. So not to say that that's what happened in this case, but just to say that, I think people sometimes just reflexively order these,
This patient was not on a prescribed medication for opioid use disorder. Is that right?
No, he was taking buprenorphine. So
he was. Okay.
Buprenorphine.
So let's talk about that for a second. There are some guidelines, including from the American Society of Addiction Medicine. They say that when you're prescribing buprenorphine or methadone for the treatment of opioid use disorder, it's a good thing to test the patient's urine for either adherence to that medicine. What are we looking for when we test someone's urine if they're in addiction care? Tell me that.
Yeah, well, I do think that there are things that you can discern from objective testing. For example, adherence to medications that are prescribed. I think you have to be a little careful with that because buprenorphine is a semi-synthetic opioid, methadone is a synthetic opioid. Those things are oftentimes not detected on many urine drug screens that are out there. So you have to. I think one theme that I hope we talk about today is that urine drug screens are complicated, and I think people really need to make sure they're ordering the right test if they're going to do one. But then I think whether or not patients are using other non-prescribed controlled substances or illicit opioids or other illicit drugs would be the other reason to do a urine drug screen. And you are right. Most guidelines suggest that they're performed to some degree. I would say, how often and in what circumstances are more or less absent from the guidelines. And I think the strength of evidence in terms of patient-centered outcomes, like whether regular urine drug screening reduces overdose death or improves patient satisfaction with their treatment, or whether patients stay in treatment longer who are getting more regular urine drug screens. I think there's not a lot of strong evidence to support those claims.
So that's pretty important. We're spending money, we're ordering a test that maybe doesn't have strong evidence. Do you want to go ahead and make as strong a case as possible for it anyway in the care of addiction? We're going to come back to pain in a second, but in the care of addiction,
Yeah.
what's the strong case for it given that the evidence is weak?
Right. So I do urine drug screens in my practice, it's not like I'm completely opposed to urine drug screens. I think there's two reasons that I do them. So one, I tell patients right up front, we'll do a urine drug screen every now and again to make sure you're taking the medications that were prescribed to you. And no matter what shows up on those urine drug screens, you are always welcome to receive treatment here. We want you here. We only use these tests to enhance your treatment, never to punish you, which I think is an important thing to say because patients oftentimes have been punished. These tests can be very punitive, right? People get dismissed from practices in addiction treatment centers. They get sent back to jail or prison if they're under community supervision. So the stakes are pretty high for patients. So I just make it clear this is only intended to improve your treatment. And then, the studies that have been done out there on, hey, why don't we just listen to patients, just ask them what substances they're using. I would say that about, 35% of the time, in the studies I've read at least, the patient reported substance use doesn't match the results of a urine drug screen. And so I think doing urine drug screens, if there are aberrant medication related behaviors, or which one would argue that may not be screening anymore, right? That's sort of exhibiting a symptom of poorly controlled opioid use disorder. That's just not a random screen, right? But then also just to help patients, sometimes know what they're taking themselves. I always offer, if I'm going to do a urine drug screen, to test for fentanyl because I think that is something that patients may want to know, right? If there's fentanyl in the drugs that they're using, if they don't think they're using fentanyl. And I will tell you, many patients have said, yeah, please, let's check. I should know about this. And many people have been quite surprised at the result. It's oftentimes positive, and hopefully that changes the way that they're using drugs. It allows us to increase their treatment, and then just things like not using alone, making sure there's naloxone nearby, and maybe have them think a little harder about abstinence if they know that there's this added danger in using out there. So
there is a downside to this testing process, which is that it seems to imply that we don't trust patients. And maybe it even reasserts something that you wrote in your piece, a power dynamic. You wrote that in your piece in JAMA Internal Medicine. Can you talk about what is the power dynamic and should we be concerned about that?
Yeah, well, I do. I think their urine drug screens are complicated in terms of sort of the dynamics between patient and providers. And I think one part of that has to do with the circumstances in which people have done them in the past, right? So a lot of times patients are coerced to do these tests, right? We don't force people to get an A1C, we don't force people to do other lab work, but this, I think it's sort of implied in most of the treatment environments in which patients are getting urine drug screens that this isn't an option. You're going to do this now, and in many cases they're observed urine drug screens, right? So I find that to be humiliating and can really just sort of be a little traumatic for patients. And in many cases, patients have told you that, look, I had a slip up. I used this substance since the last time we talked. And I just feel like then saying, okay, great, now go pee and prove it, just sends this signal of mistrust. And not to say that you should never do that, but I think providers should think hard about what kind of messaging you're sending, and whether or not you're doing these urine drug screens to actually improve patient care or just as some sort of routine check the box kind of behavior.
What about just saying, hey, I don't know what I think about this test, but my board of medicine and my hospital require me to order it, so I'm ordering it. Sorry, but you're going to have to do it. Otherwise, I can't write your prescription, whatever it is, whether it's for pain or addiction. Is that a good way through the conversation or not? And I'm trying to be a little provocative. I got to order this. I don't know what it means, but they make me do it.
Sometimes in the context of chronic pain, I think, in which, people are supposed to get annual urine drug screens and, there's just no signal that this person is misusing their opiates at all. I'll just say, look, every year we have to do this. This isn't necessarily my decision. I'm sorry. And so sometimes that's true. But in opioid use disorder or other substance use disorders, I actually really try and frame it in a way that hopefully we're focused on patient health and benefit. And like I said, it's helpful for us to know if you're taking the medication, because if you're not, maybe we should try something different, right? Or if, you're using illicit opioids and you're not telling us, or using some other illicit substance, we can help with that, right? So we should know. And that's the reason I try and explain urine drug screens to patients with substance use disorders that way, rather than just like, oh, I have to do this. I'm sorry. There's no utility in this at all.
So I'm going to play out a hypothetical before we come back to your patient. So imagine I'm seeing a patient. They're on buprenorphine from me for their opioid use disorder. They have not, I've asked if there have been use of other substances. They've said, no, doc, things have been good. Cocaine pops up on maybe a screening test and a confirmatory test. And how am I going to say to the patient, do I say, I am upset, you lied to me? Or do I say, gosh, I got a funny thing to talk about with you today. Something happened when I looked at your labs. Like, what is the right conversation at that point in time?
Well, I thank you for asking this. I love this. And this is something I talk about with our trainees all the time when they come in, because, the conversation that happens is eventually we'll get to the urine drug screen results and substance use, but almost always starts with, how are you doing? Like, what's new in your life? How are the relationships in your life? Are you working? What's your housing situation like? And we just kind of go through that probably for half the interview every time, regardless of whether we've done a urine drug screen or not, because I just believe that functional outcomes, right, are so important to patients and such a huge marker of success in treatment, right? Because if you have a poorly controlled substance use disorder, you're not getting a new job and repairing those family relationships and, dating somebody for 3 months and having a positive experience with that and getting permanent supportive housing. That takes a ton of work. So I always start there. And then usually at some point, if in the hypothetical that you bring up, I'll just say, the last time you were here, we did a urine screen and it was positive for cocaine. And then I just stop. And then I just let them tell me what they think,
Okay. So you've had this conversation. It's potentially a good conversation, or at least one that's human. You say, by the way, I need to let you know, or I want you to know this. And then you just stop. Is it silent for the next half hour? What happens?
No, patients, I would say that you picked cocaine, and I would say cocaine is one of those things that a positive result, even on an immunoassay screen for cocaine, is pretty predictive of actual cocaine use. So in my mind, I'm saying like, look, this isn't like, I took some NyQuil and it turned positive, which for some things on an immunoassay based screen can absolutely be the case. But if they say like, look, I didn't use it at all, I didn't do anything, that wasn't me, I just say, look, okay, fair enough. The reason we do this test is because cocaine could be, for example, adulterated with fentanyl. That could put you at increased risk of dying. And you're putting all this work into treatment for your opioid use disorder right now. I just want you to stay safe. That's the whole reason we do these things. Do you have any thoughts about that? And I really just try and make it as easy as possible for somebody to say, okay, fine. Like, I got super stressed, and like, this was my coping mechanism and I haven't done it since, or I'm still struggling with this, or, whatever it is. And I don't know, anecdotally, I don't find that very often people do anything other than say like, yeah, I had to slip up with this, or I'm still struggling with this. And I think that has everything to do with trust and rapport.
I think this is magnificent. I think the conversation we're having is really about the nature of our work as physicians and why we do this and what matters. And I think just before exploring that further, a couple of things struck me. First, the fact that there is, and you wrote about this in your piece, that there are, widely divergent practice patterns, even within the same clinic, regarding what to do when a test result comes back. And one of the things we all learn in medical school is that a test should only be done if we know what to do with the results. And what's extremely clear is that it's all over the map. And so that should be a huge red flag to us in the profession that something ain't right. So when we get into this debate about whether this testing is good or bad, we're almost jumping the gun. I mean, how can we even have that conversation if we don't even have any agreement about what to do with the information? As you said, there are clinics that have zero tolerance policies, which just sounds like it's punitive, which is you're positive, we're stopping everything, okay? And that's brutal. There are other clinics that, and maybe other doctors in the same clinic, that take a much more flexible approach, regardless of which one you think is right. I think we can all agree that the absolute lack of any consensus about what to do is itself something that should alarm us greatly. I was comparing this to, I'm also a med peds physician, and the question, of course, is doing pregnancy testing, for instance, on a young woman who comes in, a teenager, with symptoms that could be associated with pregnancy. It's widely accepted that whether they say they've been having sex or not, you do a pregnancy test. Even if they say, Doc, I'm definitely not having sex, I've never had sex, you still do a pregnancy test if they're throwing up and all the symptoms, they have abdominal pain. But why? Because it's obvious what you're going to do if the test results are positive, right? We all know that if the test result comes positive, then it's a game changer. It's going to profoundly approach how you manage that patient clinically. And yet when it comes to this subject, urine drug testing, we don't know. And that's why I think this really turns the spotlight on us as a profession. We have to start asking ourselves tough questions about what are we doing? And that is kind of the thought process, I think, that at least pushes me in the direction to think about this as just an example of a much larger conversation we need to be having about what our jobs are as doctors.
Let me ask this. Your colleague in this story, presumably was a colleague who ordered a test. I'm going to guess that they didn't ask the patient's permission before they ordered it. And by the way, when I'm ordering these tests, I'm often saying things like, I'm required to. I'm also not asking their permission. But there is an argument that I think is ethical that says, gosh, when you test people who are adults, you ask their permission before you do it. So are we routinely violating a core medical ethic in sort of saying, whatever, my wiggle language, which says, the board and the hospital expect me to order this. Are we basically consenting to violate medical ethics across the board here?
Well, I do think there is an ethical piece to this, and I think that this really often in many people brings them back to a place in which they were, like I said, their experiences in coerced treatment settings or community supervision settings in which, like I said, they were doing observed urines and the stakes were incredibly high, right? They basically were like, if this test is interpreted incorrectly, like you're going back to prison, right? And so I just think it just awakens a lot in people, and it's just so anathema to what we do in primary care. So I will say, in my own practice, which I think a point that's come up several times on this podcast is that, I can share my practice, but it's not like I am adhering to any particular guideline here. I'm kind of flying in the dark, just like everybody with this stuff. But, if somebody says like, look, I had a slip up, I used methamphetamine, 2 days ago, nothing horrible happened as a result. There was no overdose event or anything like that. And we were planning on doing a urine screen. I'll usually say like, look, I would rather do this at a time where this result is going to be useful to you. And like, you're going to feel maybe more proud of this result. We don't need to do this today. If it's not, you've already told me like what's going on. So sometimes I'll offer, I'm like, if you want, we could do one. We could send the fentanyl testing if you're curious, if like that's what's in the supply you're using. But, if you also want to do one another time, like, let's wait, and let's take what you've told me and let's use that to help like refine our treatment supports. And, are you engaged with like peer support services that might be able to help? Is there a contingency management group we can get you in that may help with stimulant use stuff, and just go in that direction rather than, saying like, thanks for telling me. Now you can't, we're not going to fill your prescription until and it doesn't matter that you just peed before you came in because, we were running 30 minutes behind and you couldn't hold it that long. Like, you have to drink water until you can pee for us again or something like that,
Now, we are going to come back to the pain care issue in a moment, but I do want to ask, I want to highlight that at least in the opioid use disorder care arrangement, where you're prescribing a controlled substance, it appears that you're not very likely to stop the medication that the patient may be relying on for opioid use disorder. And the guidelines also don't seem to suggest that you would do that, correct?
Right. Even if they're not taking buprenorphine, even if their buprenorphine is negative, it's not like we just don't prescribe them buprenorphine anymore. We bring them back for more frequent visits and consider things like residential treatment and try and figure out what's going on. Right. But yeah, exactly. But we don't just tell them to take a hike. You know what I mean? Ever.
So what happened with the patient in the story? This patient of yours who's come out of prison, they were tested sort of for a back pain visit. It's positive. They're upset. You spoke with that patient and you had a decision to make about what to say about this test with a patient who was already upset and felt accused, even without you accusing. What did you say?
Yeah, I didn't have anything scripted at the time. So I just told him that, look, we trust you. And I don't know what happened with this urine screen result. It seemed like it was performed out of context. And so I'm kind of tempted to not make a big deal out of it. But if you want, you can repeat the test. And if it makes you feel like better to show us, that this was an aberrancy, that the test was maybe perhaps inaccurate, or that at least that you're not taking hydrocodone. But if you don't want to, that's fine. Like that. We're going to just say that wasn't part of your treatment. And if you're honest with, you've always been honest with us, and I don't have any reason to believe that you're not this time. And he actually wanted to repeat the test, and lo and behold, it was positive for buprenorphine and no other opioids. So there you go.
I had assumed for years that, and again, I'm a primary care physician without any special training in addiction medicine. We were admonished for years that we needed to be ordering these tests and so forth. And I just had always assumed that it would be irresponsible not to, because I just thought that, oh my God, if I don't do this, a patient could die. They could be taking something I don't know about. And if I have them on opioids and I don't test for it, and of course you can't quote unquote trust patients because they have addiction, they may not tell you, then, God forbid, they could overdose and die. And I think what I'm hearing from you and from reading from some of the links in the articles that we were looking at is that there isn't evidence for that there isn't evidence that urine drug testing saves lives. Is that the case?
Yeah, I don't think there's any evidence that shows a mortality benefit from doing like regular urine drug screening at all.
So let me turn to pain. We have 8 to 10 million patients, maybe a little less, maybe a little more, who are receiving prescribed opiates on a long-term basis. There are probably many more who come into emergency departments or have a surgery and receive them on a short-term basis. There are a variety of guidelines. Many of them mention urine drug testing in any patient with pain where the consideration is to prescribe an opioid. Do we have evidence on that?
Well, I do think that is there are a couple of differences in that scenario, because one, a positive, like a aberrancy on a urine drug screen actually does change your management. It's almost like the urine pregnancy test, right? Like, because we know that patients taking long-term opioid therapy, like some subset of them will develop an opioid use disorder, which the treatment of which is not prescription opioids, right? It's medicines like buprenorphine or methadone or things like that. And so I do think that, especially if patients are demonstrating aberrant medication-related behaviors, like, frequent early fills, or certainly like an overdose event or something like that, I do think urine drug screening plays a different role in that setting. Whether or not there's a lot of evidence, and I would say there's more robust evidence for urine drug screening in patients who are on chronic opioid therapy, but I still think that how we treat patients as a result, right? Which, we talk about patients being dismissed from addiction practice for an aberrant urine drug screen. I mean, think about patients from the chronic pain setting getting their opioids cut off, sometimes for no reason, but like, the slightest hint, THC on their urine drug screen, which
marijuana.
Why are we even testing that? Yeah, exactly. It's like, legal for medical purposes in 38 states, but like, THC, no more opiates, you're gone. I think that stuff happens, and there's certainly no evidence to support that practice.
So let's talk about what happens with these tests in pain care. So as an example, I have many in mind, but one that comes to mind, and I'm probably going to be changing a few aspects of the case, but there's a guy out there who had been on long-term prescribed opioids. I don't know that all people would have agreed that the original diagnosis would have led every doctor to prescribe opioids, but they were stable. And they got a letter from their doctor that said, we are going to stop your opioids because you've tested positive for crystal methamphetamine. Crystal methamphetamine. That's the words used in the letter. That I remember for sure. And in some interaction with this guy, I was trying to get a copy of the letter to see what test it was. I was a little worried that it was just a standard screening test. I wasn't really sure if it was the more detailed GCMS. I can't even remember what the, gas chromatography test, but maybe just a screener. But it said crystal methamphetamine, we need to stop your opioids. Can you help us understand what is this issue with methamphetamine in tests? And what do you think about stopping at that point?
Yeah. I mean, first of all, like a letter, like that is just unacceptable, right? Like this needs to be a conversation, not like a letter, right? I mean, that's just is unbelievable. Just because, like the repercussions for the patient are huge. And Stefan, you've done a ton of work in this area showing that, like that this potentially could be a fatal decision that is made on behalf of the provider, right? Because, the rates of suicide and severe depression and, illicit substance use and stuff are well known to increase as a result of people having their prescription opioids abruptly cut off. And if this guy is using methamphetamine, which who knows, that is like a special, that he's just one step closer to using other illicit drugs that could, he could die, right? Like, and so just like a letter saying that's all, folks, is I just feel like, like people should have their license taken away for that kind of stuff, in my opinion, not to get up on my soapbox too much. But anyway, I think that, so if it is, so there are two flavors of tests predominantly. There's aminoassay based tests, which are like can be done point of care and are much, much cheaper. I would say probably about 10% of the cost of the gas chromatography mass spec tests that are sort of the confirmatory testing, and they each have their drawbacks. But aminoassay based testing, especially amphetamines on aminoassay based testing, are just super prone to both false positives and false negatives, right? Because if they have a higher cutoff for substances than gas chromatography based testing. So, if someone could have used and it'd been a couple of days, it won't show up, even though if they were. So that's a false negative. And then many, many substances will trigger, especially with amphetamines, false positives. Things like bupropion, the antidepressant, is a classic one, or Sudafed can trigger a false positive.
Trazodone. Trazodone.
Yeah, trazodone. A million things. So I would, if I were that physician, I would really look through that patient's prescription med list and bring him in and talk to him about it. Because, there's, I just think you can't make an off-the-cuff judgment about that based on the results of especially an aminoassay based screen. If I was that patient, I'd be doing the same thing. Like, let me see the test results,
So I know what the normal response to this is from a lot of doctors, which is that's very nice of you, you academic doctor with all your expertise. But I'm out here in the community and my board is raising a ruckus about the need to get prescribing down in this community. In fact, there are doctors who've been disciplined. There are other doctors who were investigated. I got to keep myself in business here. I can't just give up my career because of your lofty ideals from the University of Utah. Is there a reasonable response to such clinicians?
Yeah, I would just say that, if you're not prepared to do, if you don't have a good monitoring and safety plan, including like what to do with the test results of monitoring and safety tests, then, you probably shouldn't be prescribing the medications in the first place. But, and that doesn't mean to stop prescribing them abruptly to patients, right? This is like not a patient issue. There should be incentives, either through like quality measures or, leadership based decisions or, training for physicians on just how to do this right. And then there should be accountability. So I would say that I just think you can't just kind of do it halfway, right? You can't prescribe opioids and then not really do the monitoring part correctly and then just dismiss people kind of willy-nilly because you're not really doing due diligence,
Have there been situations in which physicians have been sanctioned for not ordering urine drug tests? And if so, what do you know about them?
I don't think so. I certainly don't know of any situation in which people have not have been sanctioned for not ordering urine drug screens. As Stefan was saying, there are plenty of practices in organizations out there that, for example, for patients in chronic pain, to get a annual urine drug screen, and that is like in some national quality measures for pain management as well, and chronic opioid therapy. I think for addiction, it's way less structured and there's less evidence, and I don't think anybody's being sanctioned for not ordering them. In fact, many physicians don't order them at all, right? So
I have read disciplinary evaluations that suggested that the continuation of the prescription of an opioid for pain with a test result that was positive could be seen as a bad mark against the prescriber's decisions. I won't know the outcomes of those cases, but there clearly are some people who are paid to evaluate records for medical boards who take a dim view of continuing the prescription if the test result has been positive. Again, I'm saying that carefully because I don't know the outcomes of those cases.
it's tricky though, just so you know, especially if you're going to use the more sensitive testing, right? They're very prone to picking up impurities and metabolites, right? So it's, for example, is I think most emergency medicine providers will tell you it's not uncommon to have somebody who's using heroin come into the emergency room. You know, they get a urine drug screen, maybe for an altered level of consciousness or something. It's not positive for heroin or its direct metabolite at all, but it's positive for codeine and morphine, you know, and I think you get familiar with those the sort of metabolism pathways of certain opioids. But just to say that there's tons of stuff that can pop positive on those tests. For patients with chronic pain, for example, if you're taking hydrocodone, well, there's a minor metabolite of hydrocodone is hydromorphone. And so if you're doing super sensitive testing, that's going to be positive, right? At low levels. And if you don't know how to interpret the quantitative part of that, it's going to look like your patient's taking hydromorphone that's not prescribed to them, you know, and that happens like that. I think that happens all the time. So that's just to say, like this is something we were kind of alluding to at the beginning of our conversation. You really have to know what you're doing when you order these tests. I think people look at them as these very binary, is it positive or is it negative? And that's it. But actually there's a ton of nuance to these tests. And if you don't learn it, then, or you don't have a local expert that can help you with it, you really can like do a lot of harm to patients. So I think if you order the tests, it is sort of incumbent on you to learn how to interpret them correctly, you know.
And at our hospital, we do have some advisory teams that provide advice. Clinicians don't always take advantage of it. Sometimes they react rather than ask for help. But there are 2 teams that can literally request an electronic consult to help evaluate the test result and figure out what to do with it. Probably we need more of that.
Yeah, we have a pharmacist in our institution that has made themselves available. Like, please, you know, ask me for help, because this isn't just an opioid thing, right? Like, there's tons of benzodiazepines that don't regularly show up on common, you know, urine drug screens, and then people kind of providers, to their credit, are like, you know, not just cutting people off, but saying like, they asked me, what's going on with this? Like, should I be worried about this? You know, which is good. You don't have to know everything, but you should at least. The response to those kind of aberrancies should be like, boy, let me make sure this isn't a testing thing right before I make clinical decisions based on this.
I remember you're saying that I think I saw that metformin and diphenhydramine can produce false positive urine drug screens. What do they produce? What's the false result that you typically get with those?
Oh, that's a good question. Diphenhydramine definitely is the amphetamines. It can turn positive for, it can cause an immunoassay-based test to turn positive for amphetamines. And actually, I think metformin, that's the case as well.
So just stepping back, picking up on I think what is the larger theme of your piece and some of the comments you've made today having to do with our goal as healers. You know, I think sometimes we lose sight of that and we get obsessed with a number. In this case, we get obsessed with whether a drug screen showed something or didn't show something. I also think that sometimes our own egos get involved. So when you mention that letter being sent to a patient, which is brutal, as you said, it's almost as if the doctor is saying, how dare you, you lied to me. I'll show you. And I think, you know, one of the things we talked about and I wrote about in my book on becoming a healer is when physicians lack boundary clarity, when they're not able to distinguish between their own inner emotions and reactions to things. And it blinds them from seeing what's in front of them, which is an enormous amount of uncertainty, a patient who is coping with a great deal. And instead, what you get is a physician who's reacting to their own emotions. And in this case, emotions that are not really serving their patient well. And that can lead them to lash out and send a letter, which is an incredible abuse of power. And I think that's why you reacted as you did, saying, this is not the kind of person, or certainly not the way of practicing medicine that should be considered acceptable. One of the things you talked about earlier in the discussion, and I think your essay got at this as well, is that there's so much more that we should be thinking about when we're caring for patients who have addiction. We're really focused on the question of function. And what do we want for our patients? As doctors, the same things we want for all our patients. We want them to have healthy lives. We want them to have meaningful relationships. We want them to be productive. What comes with that, of course, is a healthy lifestyle and so forth. And as you pointed out, and this was well described in the patient that you wrote about, he was doing all that and more. And to then all of a sudden be told, oh, well, we have this number here, or in this case, this result. And this result potentially means that all of that doesn't count. And that's the message that you get when you're incarcerated, right? It's a very punitive environment. And what you're saying is we can re-traumatize these patients by doing that. And one of the things I think we've learned in recent years is that in an environment of systemic racism, let's face it, addiction disproportionately and opioid abuse often affects patients who are already in so many ways affected by systemic racism, are much more likely to be incarcerated, are much more likely to be treated punitively. If we're healers, we have to be extremely mindful of that and be so careful that we're not sucked into reinforcing that behavior by doing it ourselves, and that that we have to remind ourselves constantly that as physicians, our job is to heal and to focus on what's going on in the life of this person and what can we do to support it. And I think, as you pointed out, that doesn't mean we completely write off the use of this test, but this test becomes one small tool among many that can be helpful in the management of a patient. And we have to be incredibly careful not to use it in the way that it's so often used. And I really liked the way in which you modeled using it. In the example that you gave when Stefan said, well, what would you say to your patient when they have a positive result? You said, well, I wouldn't say anything initially. I would talk about all the other stuff first, and then I would just put it out as an observation. And let's see what they have to say. And I thought that was beautiful. I really thought that was an important way of modeling how we can use these tests. And it's so different from the messages that we're getting through so many other venues. And unfortunately, those messages are sending us in entirely the wrong direction. And in some ways are unwittingly making us part of a system which traumatizes people and in some ways contributes to systemic harm.
Yeah, I think that is very beautifully put, and I agree with that 100%.
That was beautiful from both of you, and I am really thankful and moved that we were able to have this conversation today. I think it's going to make a big difference in the life of some of the clinicians who listen to this podcast, also some of the people who go and seek care as part of this podcast. Thank you so much for being on this episode, Michael.
Oh, it was truly my pleasure. Thank you both.
Yeah, I was so glad to have you, Michael. And quite honestly, I'm sort of in awe of both of you because you both are experts on this topic. And so as a primary care physician, to be able to spend this time with the two of you together was really wonderful. So, and I just being able to do that makes me appreciate how much our listeners are going to enjoy this as well. So thank you.
Very good.
Thanks, guys.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have, and you haven't already subscribed, please consider doing so now. Take care, everyone.